Good evening, everyone. Today, we will discuss a clinical case titled Paraparesis in an Elderly Female, a case that explores the intersection of neurology, endocrinology, and geriatrics, and highlights how a multifactorial approach is often essential in internal medicine. Our patient is Mrs. Miramana, a 78-year-old female. She was admitted on the 12th of July 2025 at our hospital. Initially placed in the female medicine ward, she was transferred to the emergency observation ward on the next day, and the clinical examination was performed by me on the 15th of July 2025. Chief complaints. The patient presented with 3 major complaints: progressive weakness in both lower limbs over the last 20 days, inability to walk independently for the past 10 days, and decreased sensation in all 4 limbs, also developing over the last 10 days. These symptoms prompted further neurological evaluation and inpatient care. History of present illness. She was apparently in her usual state of health until about 20 days or so. At that time, she experienced a sudden onset of weakness in both lower limbs, which progressed steadily over the next 2 to 3 days. About 10 days before this episode, she had reported mild calf pain, for which she took some homeopathic medications. Following that, she started noticing a sense of heaviness and tingling in the legs, gradually worsening into frank weakness. Currently, she is unable to walk without assistance. Negative history. There's no history of trauma, falls, or any direct limb injury. She did not report bowel or bladder disturbances, such as incontinence or retention. There were no preceding febrile illnesses, upper respiratory symptoms, or diarrheal episodes, which helps to rule out post-infectious Guillain-Barré syndrome. No history of tuberculosis contact, unintentional weight loss, or other constitutional symptoms. Importantly, there was no recent vaccination either. Past medical episodes. She reported a similar episode of limb weakness about 1 year ago, which resolved spontaneously after taking homeopathic treatment. She had no past history of hospital admission or surgical intervention, and she has no known drug allergies. Known comorbidities. She is a known case of hypertension, well controlled on regular medications. She is also diagnosed with primary hypothyroidism and has been on levothyroxine 50 micrograms daily. However, recent thyroid function tests suggest iatrogenic hyperthyroidism. TSH suppressed to 0.012 micro-IU per milliliter, FT3 within normal range, and FT4 mildly elevated. She has no history of diabetes mellitus, but her HbA1c is 6.9%, which is in pre-diabetic range. Drug history. She has been regularly taking levothyroxine and antihypertensives. She has no history of statin use, steroids, or anti-tubercular therapy. Also, she has no known exposure to organophosphates, insecticides, or heavy metals. Personal history. She follows a mixed diet, does not consume alcohol, and has never smoked. There's no history of drug abuse, and she lives in a hygienic environment. She reports normal sleep and appetite, and no issues with bowel or bladder functions. Family history. There is no history of similar neurological conditions in the family. No genetic or hereditary disorders have been documented, and there's no family history of autoimmune diseases. Activities of daily living. Due to her current condition, she has difficulty standing and walking without assistance. She is unable to perform fine motor tasks effectively, such as buttoning clothes. She now requires help with dressing and bathing, although she is still able to communicate and has no issues with swallowing or speech. General examination. On general physical examination, pulse rate was 78 per minute, regular. Blood pressure was 150 by 70 millimolar of mercury. Respiratory rate 16 breaths per minute. SpO2 98% on room air. And the patient was a febrile. There were no signs of pallor, cyanosis, icterus, clubbing, or pedal edema. No lymphadenopathy or thyroid swelling was seen. Higher mental functions. She was alert, conscious, and oriented to time, place, and person. Her mini-mental state. Examination score was 25 out of 30, slightly reduced, but without clear cognitive deficits. Memory, attention span, and comprehension were all preserved. Neurological examination. Neurologically, her plantar reflexes were non-responsive bilaterally. Muscle tone and bulk were normal across all limbs. There were no fasciculations and cranial nerves were intact. There were no signs of facial deviation, no ophthalmoplegia, no ptosis, nystagmus or bulbar involvement. Sensory system. Examination revealed that touch, pain, and temperature sensations were reduced in both lower limbs. Her vibration and position sense were also subjectively reduced. However, there was no clear dermatomal pattern suggesting a diffuse or non-root lesion. Joint and musculoskeletal examination. There were no joint pains, no swelling, and no deformities. Upper limb movements were not restricted, and there were no contractures. Power examination showed, for upper limbs, 4 out of 5, for lower limbs, 2 out of 5. This clearly correlates with her presenting complaint of paraparesis. Deep tendon reflexes. Her biceps, triceps, and supinator reflexes were present and symmetrical. Knee and ankle jerks were absent. However, the plantar reflexes remained mute bilaterally, which again supports a peripheral neuropathic process. Coordination and gait. She was unable to walk independently, owing to motor weakness. Both finger, nose, and heel shin tests were impaired bilaterally, indicating poor coordination. There were no tremors and no cerebellar signs were observed. Lab investigations. Hematology and biochemistry. Her complete blood count showed hemoglobin, 10.6 grams per deciliter. Mean corpuscular volume was 73. Total WBC 11,000, with normal differential. Platelet count was within normal limits. Renal function test showed urea, 31 mg per deciliter. Creatinine, 0.7 mg per deciliter. Electrolytes. Sodium and potassium were within normal limits. Her fasting blood glucose level is within normal limit. Endocrine and nutritional profile. Her thyroid profile showed a suppressed TSH, a normal FT3 and an elevated FT4, pointing to iatrogenic hyperthyroidism. As for nutritional markers, vitamin B12 was 150.1 picograms per milliliter, which is deficient. Vitamin D was 17.26 nanograms per milliliter, also deficient. Lipid profile. Her lipid profile showed total cholesterol, 131, LDL, 73, HDL, 36, triglycerides, 110, VLDL, 22. All are within normal range. Urine albumin and ACR. Urinalysis showed trace albumin, and her albumin to creatinine ratio was 199.37 milligrams per gram, indicating nephropathy. Now coming to the neuroimaging. A non-contrast CT scan of the brain was performed. It revealed focal areas of near CSF density in the bilateral basal ganglia, which are consistent with old lacunar infarcts. There were paraventricular hypodensities, suggesting chronic small vessel ischemia. Additionally, we noted mild sulcal space widening, which can be attributed to age-related cerebral atrophy. Overall, the imaging showed grade 1 global cortical atrophy, quite expected in an elderly individual with vascular risk factors. Echocardiography. Echocardiography showed that her left ventricular ejection fraction was 65%, which is within the normal range. There was evidence of concentric left ventricular hypertrophy, and a diagnosis of grade 1 diastolic dysfunction was made. Importantly, her systolic function was preserved, which rules out significant structural heart disease. Consolidated investigation summary. So now, consolidating all the investigation findings. We're looking at a case of iatrogenic hyperthyroidism, likely due to overreplacement of levothyroxine. There is vitamin B12 and vitamin D deficiency, which may contribute to neuropathy. There's early nephropathy, possibly due to borderline diabetic control. Neurologically, we have evidence of chronic ischemic changes and mild cortical atrophy. Cardiac evaluation shows left ventricular hypertrophy with diastolic dysfunction, although systolic function remains good. Nerve conduction study. A nerve conduction study was carried out and it showed bilateral demyelinating axonal polyneuropathy, involving both sensory and motor components in all four limbs. This electrophysiological pattern strongly supports a peripheral neuropathy, which is both demyelinating and axonal in nature, suggesting a chronic, possibly metabolic or inflammatory etiology. Differential diagnosis. Based on the clinical picture and investigations, I considered the following differential diagnoses. First, chronic inflammatory demyelinating. Polyneuropathy, or CIDP, is a possibility given the progressive nature and symmetrical sensorimotor involvement. Subacute combined degeneration due to vitamin B12 deficiency is also likely, especially with macrocytosis and low B12. Then, given her age and borderline HbA1c, diabetic sensorimotor polyneuropathy must be considered. Hyperthyroidism-induced neuropathy, resulting from thyroxine overuse, also fits the picture. Another possibility is small vessel ischemic paraparesis, considering the CT findings. In an elderly patient with new-onset neuropathy, we also keep paraneoplastic neuropathy in mind. Lastly, motor neuron disease was considered, but it is less likely here there were no fasciculations or bulbar signs. Final diagnosis. After careful evaluation, the final diagnosis is demyelinating axonal sensorimotor polyneuropathy, likely multifactorial in origin. Contributing factors include iatrogenic hyperthyroidism due to excessive levothyroxine, vitamin B12 and vitamin D deficiency, chronic small vessel ischemic changes in the brain, and possibly borderline glycemic dysfunction. Each of these individually may cause neuropathy, and in combination, they explain the clinical picture comprehensively. Management was planned in a stepwise and multidisciplinary approach. Firstly, thyroid levels were closely monitored and levothyroxine dosing was adjusted. She was started on vitamin B12, folic acid, and vitamin D3 supplementation. We also initiated physiotherapy and limb support to prevent deconditioning and aid in functional recovery. Regular neurological follow-ups were planned to track improvement. And finally, nutritional counseling was provided to optimize her dietary intake and micronutrient status. Prognosis. The prognosis in this case is cautiously optimistic. We expect a gradual improvement over several weeks, provided she remains compliant with medications and physiotherapy. However, the risk of recurrence or progression remains, particularly if thyroid control or nutritional status is not maintained. Long-term follow-up is essential, especially to manage vascular risks and thyroid hormone levels. Follow-up strategy. We have structured her follow-up in a phased manner. At 1 week, we'll reassess limb power and sensory function. At 1 month, we'll repeat thyroid function tests and check vitamin D and B12 levels. At 3 months, we plan to repeat renal function tests, lipid profile, and urine ACR. At 6 months, if symptoms persist or worsen, repeat imaging may be indicated. This ensures close monitoring and timely intervention if needed. That brings me to the end of my presentation. Let me close with a quote by William Osler that resonates deeply with our clinical practice. Medicine is a science of uncertainty and an art of probability. Thank you all for your attention. I'm happy to take any questions or feedback. Please write your valuable feedback and questions in the comment section.